by ensuring that the availability of the drug is in public interest, the health products are safe, efficacious, and of acceptable quality, the production site and manufacturing operations comply with international current good manufacturing practices. Potentially useful products that need to be deployed in containing epidemics and pandemics need to be fast-tracked in making them available in the market. The Pharmacy and Poisons Board has instituted internationally accepted emergency use / compassionate use authorization for quick authorization of treatments and diagnostics to combat the effects of COVID-19 disease. Through this procedure, the PPB has issued EUAs, or emergency use authorizations, for in vitro diagnostics for detection of COVID-19. Ensuring a steady supply of quality, safe, and efficacious health products and technologies is therefore a key strategy in combating COVID-19 pandemic in the country. The quality and compliance of specifications of health products and technologies used in the management of COVID-19, for instance, alcohol-based hand sanitizers, personal protective equipment, such as surgical face masks, and medicines, is critical in this fight against the pandemic. In light of the above, there is need to continuously monitor and ensure quality of products circulating in the market in order to effectively combat COVID-19 pandemic. In the period between 20th April and 30th June 2020, the Ministry of Health, through the Pharmacy and Poisons Board, carried out quality analysis of alcohol-based sanitizers and surgical masks circulating in the Kenyan market. 130 different brands of alcohol-based hand sanitizers in the market were analyzed, and those failing to meet such standards removed from the market. In the preliminary results analysis of the first set of 80 samples of these alcohol-based hand sanitizers, 98.75% of them complied with the KEBS standard on alcohol concentration. However, when the next batch of 50 samples were tested, only 13 complied with the KEBS standard on alcohol concentration. Some of the failing products were found to contain methanol. The Pharmacy and Poison Board also, once they have deemed the product not suitable for the market, if it is a local manufacturing company, they do work with the local manufacturing company and provide technical support to them to be able to improve the quality and manufacturing processes so that their products meet the required standards. Currently, the Pharmacy and Poison Board is also undertaking market surveillance of PPEs in all the counties, starting with Western and Nyanza regions, to monitor quality and implement regulatory actions. The PPB also carries out studies to monitor previously unreported adverse effects of medicines and medical products after they have been licensed for use. This normal practice by medicine authorities is called pharmacovigilance. To assure the safety of COVID-19 patients during their course of treatment, the PPB is also conducting countrywide pharmacovigilance of health products and technologies used in the management of COVID-19. The data that will be obtained in this important retrospective and prospective study will assist the country in linking the outcomes of treatment to medications, patient factors such as comorbidity, probability of getting adverse drug reactions or events, among others, during the course of treatment of COVID-19. This data will also contribute greatly to the body of knowledge in the management of the pandemic. The Ministry of Health recognizes the importance of research in the race to develop novel treatment and preventive remedies for COVID-19, such as medicines and vaccines. Therefore, in solidarity with all countries in the world and global bodies, such as the World Health Organization, the Ministry, through the Pharmacy and Poisons Board, is responsible for the authorization of clinical trials to test such products. The Board has a robust clinical trial review process undertaken by an expert committee drawn from various relevant fields. The PPB has so far received a total of 7 applications related to COVID-19 clinical trials. These applications propose the use of different products, including convalescent, monoclonal antibodies, repurposed drugs, and radiotherapy. Approval for such studies comes with strict conditions, including submission of monthly progress reports, and that are subject to regular monitoring to ensure compliance with legal, regulatory, and good clinical practices compliance. Fellow Kenyans, turning now to our COVID-19 statistics for today, 102 people tested positive from a sample size of 2,668 tested in the last 24 hours, bringing the total number of confirmed COVID cases in the country to 35,205. Our cumulative tests now stand at 477,145. From the confirmed cases for today, all are Kenyans except 9 that are foreigners. In terms of gender, for the first time, there is an equal share of 51 for each gender. The youngest is a 1-year-old child, while the oldest is 86. Distribution of cases by counties is as follows: Nairobi 41, Kitui 11, Kiambu 7, Mombasa 6, Busia 5, Turkana 4, Nyeri 4, Taita Taveta 4, Meru, Muranga 2 each, Kajiado, Machakos, Makueni, Bungoma, and Kilifi 2 cases each, Embu, Laikipia, Garissa, and Kisumu 1 case each. In Nairobi, the 41 cases come from the following sub-counties: Starehe 5, Embakasi West and Westlands 4 cases each, Kamkunji, Kasarani, and Langata 3 cases each, Dagoretti North, Embakasi Central, Embakasi East, Kibra, Makadara, Mathare, Roysambu, and Ruaraka 2 cases each, Dagoretti South, Embakasi North, and Embakasi South 1 case each. Kitui, with its 11 cases, come from Kitui South 3, Kitui East, Kitui Rural, and Kitui West 2 cases each, Kitui Central and Mwingi Central 1 case each. The 7 cases in Kiambu come from 2 cases from Ruiru and Thika each, Kabete, Kiamba, and Kiambu Town 1 case each. And in Mombasa, the 6 cases are from Jomvu 3, Mvita 2, and Kisauni 1. The remainder of the breakdown is in the document that you will receive at the end of the brief. I'm glad to inform you patients have recovered from the disease of the care program various hospitals. Total recoveries now stand at 21,310. Once again, we thank our healthcare workers for the good work that has enabled us to achieve these results. Unfortunately, we have lost 2 patients to the disease, bringing our fatality to 599. Our condolences to the family and friends of those who have lost their loved ones. Land there, and thank you.
Anita from NTV. I have 2 questions. The first one is, when you compare the death rates in Kenya to Western countries like the US, Italy, and so on, we have significantly lower death rates, just under 600 if what you've just told me. And my question is, according to the study done by KEMRI recently, they found, or they attributed the reason for low death rates to several reasons. One, a young population, and they even cited the probability that we might be immune to it somehow. My question is, could you please elaborate on that and maybe give us an idea of why we seem to be having such low death rates? Additionally, it's emerged that KEMSA hasn't delivered Septrin drugs used by HIV and AIDS patients to NASCOP. Their deadline was July, and they were instructed by the Ministry of Health to do so in January. The PS for the MOH also wrote a letter to KEMSA last week asking what the update is on the shipping. So my question is, what is the Ministry of Health stance on it, and how much did it cost, and the name of the supplier if possible?
Kadzogunga kutoka runinga ya Citizen na maswali kadhaa. Pengine kama Wizara ya Afya iweze kutueleza iwapo kama Kenya tuliweza kufikia kilele cha ugonjwa huu wa COVID-19 na ilikuwa lini, ama tunaweza kutarajia wingu la pili la maambukizi ya virusi vya corona, kwa sababu tunaona kwamba saizi nambari zinazidi kushuka kila uchao. Na pengine kiwango cha asilimia ya positivity rate, je, kama taifa tulianza kuhesabu lini? Kwa sababu tumeshuhudia kwamba asilimia ya 5.4 na kurudi chini imeweza kunakiliwa Kenya. Je, tulianza kuhesabu lini ndio tuweze kujua iwapo maambukizi yameshuka ama tumefikia kiwango gani? Na je, iwapo kama Wakenya wanaweza relax kuhusiana na hizi mambo za COVID-19 measures zenye zimewekwa na Wizara ya Afya. Na ya mwisho, tumeshuhudia kwamba kuna mikusanyiko mingi ya mikutano ya kisiasa ambayo watu wengi wanaohudhuria hawazingatii masuala ya COVID-19 na zile kanuni ambazo zimewekwa na Wizara ya Afya. Na pia hatujaona kwamba iwapo kuna sheria ambazo zinachukuliwa kuweza kuona kwamba tunapunguza hizi idadi za mikutano ya kisiasa. Je, hii inamaanisha nini nchini kwa sasa?
Nancy Okware kutoka KBC. Tumepokea ripoti mbalimbali kwamba kuna utafiti unaonyesha kwamba miili ya waliofariki kutokana na virusi vya corona haiwezi kuambukiza wengine virusi hivyo. Je, kama wizara mmepokea ripoti hizo, na je ni za kweli? Na ikiwa ni za kweli, basi katika ile harakati ya kuhakikisha kwamba wale wapendwa waliofariki wanapata ile fursa ya kuaga kwa njia bora zaidi, mnatarajia kufanya marekebisho vipi ama kutoa sheria mpya lini? Na mwisho kabisa, wale wagonjwa ambao wako katika hospitali sasa hivi, hali yao ni gani? Je, kuna wale ambao wako katika yale ama vile vituo vya kuhudumiwa ama ukipenda ICU? Shukran.
Spike ya pili, si ndio? Kwanza zile manamba ambapo tunaona haswa katika masiku zile zimepita sasa siku 4 hivi, ni numbers ambapo zinatupa confidence ya kwamba tuko katika the right direction, na kwa kweli zinaanza kutaramka, lakini sitakimbilia kusema ya kwamba flatten the curve. Maana yake bado kuna safari ndefu ambapo inatuongoja mbele, lakini tunafurahia zile manamba ambapo tunaiona. Tukiendesha mambo zetu hivi, tunaweza kuwa tumefika kiwango ile ambapo tunaweza kusema tumefika ile mahali ambapo flatten the curve. Kwa hivyo tuendelee na zile mkakati ambapo tunazo. Wananchi tunawaomba waendelee observe zile restrictions ambapo tumeweka, na tukiendelea hivi nafikiri tunaweza kufika mahali pazuri. Yes, tunaweza kuwepo na spike ya pili. Tumeona hii katika mainchi zingine ambapo zimeshafika ile kiwango ambapo wanafikiria sasa wanaweza kufungua uchumi. Kisha fungua uchumi, mara moja tunaona numbers tena kwa haraka sana zinaruka, na hiyo pia inaweza kutupata sisi. Kwa hivyo ni muhimu sana tuendelee na ile tunaifanya, tuwe na hakika kabisa, na tukiwa tunafungua uchumi tunaifungua kwa njia ambapo ya polepole inaweza kutukubalia sisi tu flatten hiyo curve na tuende polepole chini mpaka ile mahali ambapo tutafika tunasema sasa tumeshawezana na hii corona. Umefahamu? Swala ya madawa za HIV ambapo haijafika NASCOP kutoka KEMSA, hayo mimi sina habari yake, lakini tunaweza kuichunguza hiyo alafu tukupatia hiyo report wakati ingine, au labda wenzangu kama wanazo hiyo majibu watakupatia. Pia uliuliza makutano hizi ambapo tumeona ikiendelea ya wanasiasa na wengine. Mimi nataka kukumbusha Wakenya ya kwamba mkutano kama za siasa za upande wa social haijakubaliwa. Bado zile restrictions ziko, na hiyo ni kufunja zile restrictions ambapo imewekwa. So we want to say in the strongest terms that the prohibition on public gatherings, social gatherings, is still in place. It has not been relaxed. And those who are doing this kind of gatherings are doing it against the regulations that have been put in place. We want to urge them to continue to observe the procedures that have been put in place, and they also risk action being taken against them for flouting these regulations. Nancy, your question was largely to do with burials and the procedures and protocols of burials. Indeed, it is true that when a COVID-19 case, a corpse, is properly treated according to the protocols, is properly treated by being placed in a double body bag, by being placed in a coffin that is fumigated, that the risks of transmission of virus are almost nil. And of course, when the pandemic broke out, the cautions that were taken were extreme to some extent. And therefore, some of the measures were also rather extreme in ensuring that we didn't take any chance with transmission of the disease. But as the pandemic has unfolded and we have learned more and more about the disease, I think we have also looked back and seen how can we now review some of these protocols and see that we review some of them to make it easier for those who have lost their loved ones to be able to observe certain rituals as they bury them. And I think Dr. Kuria will talk a little bit about what the ministry is doing in terms of reviewing the protocols for burials. The statistics on those who are hospitalized, I don't have them on hand, but we do have that information, whether there are any of the patients who are in hospitals or that are on critical care, that are in ICU or on ventilators. It's available. I don't have it, but perhaps, I don't know, Dr. Kuria says he can provide that information. So I think I will now hand over to Dr. Kuria to respond to and add on to some of the questions that were asked. Dr. Kuria.
Thank you, Kasser Rashid. And that issue of decent barriers that obey religious and cultural norms has been a concern that has been raised to the ministry repeatedly. And I can confirm, as the CS has said, we actually finalized the revised protocols that are going to guide us in conducting barriers moving forward. In fact, we are going to address this in the course of the week as we roll out the protocols. And we hope that since we've known that that body, once the patient has passed on, is actually no longer as infective. And as long as you do not get into contact with the fluids, the effectivity may not be that high. So the measures then will be more towards avoiding contact with those fluids, and we'll be using those guidelines regarding the packaging and how you handle the body thereafter. And hopefully the protocols are going to address the concerns of stigma that have affected fellow Kenyans. You've seen others requesting that they be excused, the men who come in white. And we hope the protocols, as we roll them out in the course of the week, will probably visit some of those issues and you not see those men in white again. And we may actually be able to release the bodies to the relatives who go and bury, and as long as they follow the protocols as advised. We will, of course, monitor this moving forward. We may want to supervise the barriers, but they'll be supervised at a lower scale, minimizing stigma and the effect that we have seen in the past few months. So the protocols used to be issued hopefully before the end of this week. We are finalizing them and signing them off. On the issue of numbers of patients in hospitals, we have a total number of 664 in hospitals. Yeah? And of this, there are a total of 25 in ICU and 10 are on supplemental oxygen. We also have a number of about 1,554 that we have received reports as of this morning from the various counties who are on home-based care. So the number of critical patients who are critically ill also, as we notice a decline in positivity, we're also noticing a decline in the number of patients requiring critical care from as high as 67 in mid-July to the figure that we have today of about 27. Again, an indicator that could be moving in the right direction. Hope that answers your question. Thank you.
Thank you, Dr. Kuria. There is a question I did not respond to, and that is the question about our death rates here compared to the Western countries. Indeed, that observation has been made, and it is very true. If you look at the what we call the case fatality rate, it's about ours is 1.7%. 1.7%, meaning that every 100 or so confirmed COVID cases, only 1.7 of them, or just under 2 people, will end up dying, at least in our circumstances. This is an extremely low fatality rate, considering that in the Western countries, it ranged anything from about 4%, 4.5%, when it started in China. In some of the Western countries like Italy and others, it rose as high as 7-8%. So definitely there is a big difference in the trajectory of this disease in the Western countries compared to African countries. And this kind of low fatality rate is observed not only in Kenya, but in other sub-Saharan countries. We see the same thing in places like Ghana and Nigeria. South Africa is slightly different, being on the tip of the continent, it tends to have slightly higher fatality rate. And of course, this begs the question as to what is happening. Why is this so? This is an area of intense inquiry and research to establish why this is the case. Many hypotheses have been proposed, including, of course, the demographics. Age demographics is important. Yes, in Africa we mostly have a youth bulge. Most of our populations are young people, and we know very well the course of the disease is less severe in young people. They're mostly asymptomatic. We also know that most of our cases are asymptomatic, perhaps because of the youth bulge. Environment has been raised as a possibility, the climate and temperature. The genetics is another one. Is our genetics any different from others? Previous exposures to other infectious diseases and the level of immunity. There are many, many theories out there that need to be tested out, and I'm sure that scientists are actively looking into each and every one of these areas, because it's very important to know these differences. It could be a clue to how to deal with the pandemic in the future. Thank you.